Esophageal infections. Esophageal candidiasis, CMV, herpes infection. Esophageal candidiasis is seen in, and its investigation and findings. In immunocompromised, investigation. 1. Endoscopy equals shaggy deposit. 2. Barium swallow equals worm-like ulcer. Esophageal CMV seen in, findings. Post-transplant immunocompromised, appearance equals geographical serpiginous ulcers. What's feline esophagus? Stripped, closely spaced, horizontal striations, extending to entire circumference of esophagus, seen on X-ray, similar to cat-tiger. Feline esophagus is seen in lower 1/3 esophagus equals GERD, upper 1/3 esophagus equals eosinophilic esophagus. What's eosinophilic esophagus? Chronic immune-mediated disease with esophageal dysfunction, food antigen initiation, eosinophilia and fibrosis. Peak age 20 to 30 year. Investigation for eosinophilic esophagus. 1. Endoscopy, crepe paper appearance, furrow, rings, stacked up appearance. 2. Biopsy greater than 15 to 20 eosinophils per HPF. Treatment for eosinophilic esophagus. Topical steroids, PPIs. Esophageal motility disorders are classified according to what classification? Chicago 4.0, based on high-resolution manometry. Most common mobility disorder in esophagus. Achalasia cardia, also have high risk of SCC of esophagus. What's achalasia cardia? Failure of lower esophageal sphincter to relax. Pathophysiology of achalasia cardia. Loss of ganglionic cells in myenteric and Auerbach's plexus in lower half. Not congenitally absent, lost little by little after birth. Congenitally absence of ganglionic cells is seen in what disease? Hirschsprung disease. Types of achalasia cardia. 1. Primary, loss of ganglionic cells. 2. Secondary to Chaga disease trypanosoma. 3. Vigorous rapidly progressive. 4. Pseudo-AW malignancy. 5. AAA allogrove. AAA allogrove achalasia cardia. Allocrima, achalasia, ACTH-resistant adrenal insufficiency. Clinical features of achalasia cardia. Triad, dysphagia, weight loss, regurgitation earliest, other features heartburn, nocturnal cough, postprandial chalking. Complications of achalasia cardia. Aspiration pneumonia, lung abscess. Investigation for achalasia cardia. 1. Manometry IOC, high integrated relation pressure. 2. Endoscopy, to RO cancer. 3. Barium swallow, shows bird's beak appearance. Achalasia Eckert score. 4 parameters equals triad plus retrosternal pain. Each parameter scored 0 to 3. Management modalities for achalasia cardia. Botox, balloon dilatation, open surgery, laparoscopic surgery, POEM surgery. Botox for achalasia cardia. What an indication. Inject botulinum toxin, it causes relaxation. Indications, elderly patients with comorbidity. Adverse effects of Botox for achalasia cardia. Highest recurrence rate, repeat administration can cause fibrosis. Balloon dilatation for achalasia cardia and indications. Deflated balloon inserted to esophagus, then inflated. Similar efficacy to surgery. Best responders greater than 45 years, female, previously undulated esophagus, type 2 achalasia. Risk of perforation in balloon dilatation for achalasia is less with pressure value of less than 30 mm Hg. Surgery for achalasia cardia. Name, procedure. Heller's myotomy, cut muscles 6 cm proximal and 2 to 3 cm distal to GE junction. Response and complications of Heller's myotomy. Response equals type 1 and 2 greater than 3. Complication equals GERD. POEM surgery for achalasia cardia. Peroral endoscopic myotomy. Procedure, type of notes natural orifice transluminal endoscopic surgery. Response and complications of POEM. Type 3 response best. Complications, GERD. Best management for type 1, 2, 3 achalasia cardia. Type 1 equals Hellers. Type 2 equals Hellers plus pneumatic dilatation. Type 3 equals Poem. Day. Distal esophageal spasm, uncoordinated contraction of esophagus which cause difficulty swallowing or regurgitation. Features of Day. Females greater than males, less common than achalasia, motor abnormality of lower 2/3 esophagus. Features of contractions in Day. Contractions, repetitive, simultaneous, and high amplitude. Clinical features of Day. Chest pain, angina-like. Dysphagia, acid reflux absent. Investigation for Day. ECG, RO angina. Barium swallow, rosary bead corkscrew appearance. Manometry, confirmatory. Treatment of Day. Poem, CCBs, nitrates. Differential diagnosis for female with regurgitation, nocturnal cough, dysphagia and weight loss. Achalasia, cancer. Differential diagnosis for patient with chest pain, similar to angina, cardiac enzymes normal. Day, angina. Types of esophageal diverticuli. 1. Upper esophageal, Zenkers. 2. Mid-esophageal, parabronchial. 3. Lower esophageal, epiphrenic. Which diverticulum is the only true diverticulum of esophagus? Mid-esophageal, parabronchial. Which diverticulum of esophagus are pulsion and which are traction? Zenkers, pulsion. Parabronchial, traction. Epiphrenic, pulsion. Causes of parabronchial diverticulum. TB, histoplasmosis. Zenkers diverticulum increases risk of which type of cancer? SCC. Position of Zenkers diverticulum. Begins midline posteriorly, final position, left of midline. Clinical features of Zenkers. Regurgitation, halitosis, bad oral odor. Dysphagia. Complications of Zenkers. Aspiration pneumonia, lung abscess. Pathophysiology of Zenkers. Outpouching through Killian's dehiscence, space between thyropharyngeus and cricopharyngeus. Due to high pressure pulsion induced by discoordinated muscular contraction. Investigation for Zenkers. Barium swallow, IOC. Management of Zenkers. If large greater than 2 cm and symptomatic equals surgery. 1. Diverticulectomy plus cricopharyngeus myotomy. 2. Endoscopic diverticulopexy with cricopharyngeus myotomy. What's hiatal hernia? Condition in which part of the stomach pushes up through the diaphragm muscle. MC diaphragmatic hernia and MC congenital diaphragmatic hernia. MC hiatal hernia. MC congenital, Bach-Gallic. Types of hiatal hernia. Type 1 sliding hiatal hernia. Type 2 rolling paraesophageal hernia. Type 3 mixed sliding plus rolling. Type 4 rolling with content other than stomach. Pathophysiology of sliding hiatal hernia. Upward sliding of GE junction, length of intra-abdominal esophagus decrease. Clinical features of sliding hiatal hernia. Asymptomatic, GERD, not life-threatening. Investigation and management of sliding hiatal hernia. IOCCT with oral contrast. Barium swallow. Management, if symptomatic and large, fundoplication. Pathophysiology of rolling paraesophageal hernia. Portion of stomach migrate through hiatal opening into thorax. GE junction normal. Complications of rolling paraesophageal hernia. Herniated part undergo volvulus necrosis, hence life-threatening. Esophageal perforations types. 1. Iatrogenic. 2. Spontaneous Boerhaave syndrome. Site for esophageal perforation. Iatrogenic, upper 1/3. Spontaneous, lower 1/3, left posterolateral wall. Clinical features and investigation for iatrogenic esophageal perforation. Chest pain post-endoscopy, IOC, CECT. Management of iatrogenic esophageal perforation. If small, NPO, IV fluid, IV antibiotics, no blinding tube, pain. If large, endoscopic sealing with clips, SEMS. Surgical repair. T-tube placement and repair. Spontaneous Boerhaave, esophageal perforation is seen in vomit against closed glottis. Alcoholics. Clinical features of Boerhaave perforation. Mackler's triad, chest pain, retching, SC emphysema. Examination findings in Boerhaave perforation. Hammond's crunch, unauscultation of heart. Similarity in Mallory-Weiss tear and Boerhaave syndrome. Presentation, alcoholic with vomiting. Difference in Mallory-Weiss tear and Boerhaave syndrome. 1. Site, MW is upper GI hemorrhage, BS is lower esophageal hemorrhage. 2. Pathology, MW has splits in mucosa plus submucosa. BS has perforations. 3. Complains, in MW, it's upper GI hemorrhage, in BS it's Meckel's triad. Investigation for Boerhaave perforation. If stable, CECT. Unstable, contrast study iohexol greater than dinosol. Signs seen in Boerhaave perforation on contrast study. 1. Continuous diaphragm sign. 2. Nacclario versus sign. Management of Boerhaave perforation. If stable, septic, endoscopic repair or surgical repair. If unstable, large, do emergency surgery, cervical esophagectomy obsolete. T-tube placement and repair. What's Schottky ring? It's narrowing of lower esophagus caused by ring of mucosal tissue. Mucosal greater than submucosal ring. Site and clinical features of Schottky ring. Site, lower esophagus. Features, intermittent, non-progressive dysphagia. Investigation and management of Schottky ring. IOC, barium swallow. Management, balloon dilatation. A, B, C rings in esophagus. A, normal muscular ring. B, abnormal mucosal ring, Schottky ring. C, A, W sliding hiatal hernia. What's dysphagia lusoria? It's esophageal compression due to aberrant right subclavian artery.